Hey, this is Dr. C. Welcome to the show. I know I've talked about this before, but it is so important, especially at our age, for seniors. Colon and rectal cancer. Now it's not only just the seniors, it's a big thing now for middle-aged people as well. Oh, yes. Colon and rectal cancer. There's been a lot of advances since I started in medicine. We checked people by just checking a stool sample, smearing it on a little piece of paper, putting some peroxide on it, and looking to see if it turned blue or not. And if it was blue, we would then take what they call a rigid colonoscope, actually a rigid sigmoidoscope, because it only went up about 15, 16 inches. But it was rigid. You had to learn how to use it. So basically that was it back when I was starting out in practice. But now with all the advances and all, a lot of the screening techniques are much better now. So I'm going to talk about all of the different screening techniques that are available for us seniors and actually for middle age as well, and which ones are better. Okay, let's get on with this thing. Colon cancer is the third most common cancer in the United States. And if you look at everybody who has colon cancer, roughly 30% of them, if you ask, have someone in the family who has had previous colon or rectal cancer. 30%, it's a good number, good number. So lately, however, younger people are coming up with colon and rectal cancer. And the question, of course, is why? Obviously, the earlier we can pick it up, the better. Some people will have symptoms. You may have a change in your bowel habits. You may have all of a sudden, a lot of gas and cramps, and it won't go away no matter what you take. You may actually see blood in your stool. You may actually see it. You may have a history in the family of a lot of colon polyps as well. Or you yourself might have even had a colon polyp. You may have overweight. You may have diabetes. You may smoke. You may drink too damn much alcohol. All those things are all risk factors for colon and rectal cancer. Now, many of you may not even remember a couple of people who are important, I guess, in promoting some of these ways of diagnosing colon or rectal cancer. And remember, a screen is just that. It's a test that looks for a disease that has no symptoms as yet. So, Katie Couric. Now, Katie was a very popular journalist. In fact, she was a co-host of the Today Show. And at age 42, her husband contracted colon cancer. By the time he was diagnosed, he had stage 4 cancer. It had already spread. Age 42. And he ultimately died 2 years later of colon cancer. This prompted her to get on the bandwagon then for colonoscopy. Colonoscopies had been around for a while. Like I mentioned, we only used the old rigid scope. Then they had a flexible scope, and then colonoscopy with a nice flexible tube that went all the way around. That started back in the 1970s, actually. 1970s, you could get that. So she had it done on the Today Show. That stimulated about roughly something like a 20% increase in the number of people who then went and got their colonoscopy done. Now, back then, colonoscopy was suggested starting at the age 50 to 75. So that increased. And then, of course, it died off a little bit after that until a fellow by the name of Chadwick Boseman. You may remember Chadwick. He was the Black Panther. He was actually a very good actor, very popular fellow. He contracted stage 4 cancer of the colon as well at age 43. So, examples of young people now, and I consider that young, 42, 43, of colon cancer. So, what are all the risk factors for colon cancer? Well, obviously a positive family history, a history of polyps. They may have seen polyps in the past, or a positive family history of a lot of polyps. There are some polyp syndromes, and you may be in a family that has these polyp syndromes as well. They're genetic, but when you get them at an early age, you need to get checked a lot more carefully. And other things like some diseases, like inflammatory bowel disease, they can cause polyps, they can cause premature cancers as well. So those are all risk factors. The black race seems to be indicative of a little more of colon cancer as well. So, what do we do if you don't have symptoms? Well, you have your choice of tests that can be done. Number one, you can get stool-based tests. The stools are probably the simplest way to test for it. Just like with the bladder problems, you test the urine, you test the stool, and you look for blood. That's all we had back then. When I was practicing in the earlier days, they called it an occult blood test, an occult test. And because you couldn't see the blood, but you could pick it up in the stool. And we used the guaiac paper that came from the guaiaco tree, and that paper that you put that on, you put a little bit of peroxidase on it, and bang, it turns blue. And so we could tell a positive test. Wasn't too specific, however, because you could test and get positive from other sources of blood, animal blood, for example. You could have too much citrus in your system, or take a vitamin C. All that would cause a positive test. So there are some problems because you had to prepare yourself for that hemoccult test. So no red meat for 3 days. No vitamin C for 3 days. You got to be careful on what you eat and what you drink for those 3 days. And there were false positives and false negatives all over the place. But still, it was better than not being tested, especially if you were in a risk category. And so there are a variety then over the years of different hemoccult tests. Hemoccult 1s, which is what basically I dealt with in the beginning. Hemoccult 2, where they actually did 2 tests. They had a Hemoccult 3 as well, where you did it for 3 successive days. And then finally, they had a Hemoccult ICT, immunochemical test. That only limited it to human blood because they tested against human globulin. They would have an antibody to human globulin antigen. So all those occurred over the course of time. And then all of a sudden, the FIT test came about, fecal immunochemical test. And so the FIT test was performed. Again, you had to watch what you ate, but you could have your red meat. because it very specifically honed in on human hemoglobin. And then the fit test got a little bit better. Instead of just honing in on the hemoglobin, human hemoglobin, now it also tested for one of the common residues from cancer of the colon. They call it a methylization. And what it would do, the cancer would get rid of a lot of their dead stuff and all of their material they don't need anymore. And it included some of these biologically active things. And that was the second component to the fit test. So that's a fit plus test. Those were pretty good. They were good. Didn't compare at all yet to a colonoscopy. Now, that's a full colonoscopy. So those are the stool-based tests. Then on the scene for stool-based testing came the Cologuard. And Cologuard at first just did testing against a lot of these biologically active compounds and all, and gradually over the years worked its way up. All of these, they call them biomarkers, things that got excreted by dead cancer cells, specifically colon and rectal cancer cells. And all of a sudden now, this Cologuard began to test for more and more and more of those as they became more accurate. Then they added the fit test to that. And so now you've got a complete Cologuard test, which has over a 90% sensitivity, 90%. And the specificity, that is a true negative, went up as well, probably up to maybe 70-something%, 90% on the sensitivity. So it worked its way up very well, almost comparable now to colonoscopy. Why do I keep mentioning that comparable to colonoscopy? Because that is what is supposed to be the gold standard. So if you see what may be a little tumor, you immediately biopsy it. You immediately, if it's a polyp, you remove the polyp. So you can actually treat some of these with colonoscopy right at the same time. There are issues, and we'll deal with that now. Because after the stool-based tests, we have the visual tests, which are obviously the sigmoidoscopy. I mentioned that rigid scope and all. And because roughly sigmoidoscopy could pick up to 60% of colon and rectal cancer, 60%, because most of them occur in the lower part of the colon. Not too bad, but not as good as a full colonoscopy all the way around. What are some issues with colonoscopy? Well, obviously, number one, you have to prep. You have to clean your colon out. That's the thing that us older people just don't like. You have to drink this gallon of crap the day before. You have to watch what you eat. So you're miserable. You're up all night crapping out all this till you get nice, clear returns from your bowel movement. Now you're ready for colonoscopy. Wonderful. Well, that's one of the issues. You can get wiped out. Your electrolytes can actually go down. You can get dehydrated from just the prep alone. So, at any rate, that is the colonoscopy part. Excellent sensitivity and excellent specificity, both over 90% with your colonoscopy. Not 100, not 100%. You can still miss it. If you're not really good at doing your colonoscopy, you got to do at least 50 of them to be good at it. Then you may not reach that ultimate number of cancers, or polyps for that matter. You could also do a CT colonography. That's a CAT scan. So you drink contrast material, goes down into the colon, and they use a little tube to blow in some carbon dioxide, and then they take their CAT scan of the colon. And it's actually pretty accurate. Nowhere near as accurate as a colonoscopy, but not bad. Not bad, colonography. So you still, however, have to prep. You still need that crappy prep that you do with your colonoscopy. So stool-based, visual, and now there's blood-based. You can have a blood test that shows up some of these biologic products that are excreted by a dead cancer cell. And now they can test up to 11 of them. As I mentioned, that's the Cologuard's up to 11 now. And so just by diagnosing it based on the blood test, which does check for that, I guess they test for the methylated type of thing. It's called epiprocolon, and it detects methylated septum 9. That just tells you that it's a piece that's discarded by a dead colon cancer. That's all. But it's picked up in the bloodstream. So a nice, easy test, very quick, no prep needed. And how accurate is it? Well, it can't distinguish really an early cancer that comes from a polyp, for example. Can't distinguish that. And it's not as good at cancers that are in the beginning of the colon on the right side and rectal cancer on the other side. But still, pretty good, pretty good. They also use a thing called Guardant, which follows the course of the whole colon and rectal cancer disease. So you can see how you're doing, basically. You can see how you're doing. Is that going up in numbers? In other words, failure of a treatment, for example? Or is it staying down low? So it's used to see how things are going, not only to diagnose, but to treat as well. Now back again, I keep talking about how I started out and all, but what we had was carcinoembryonic antigen, CEA. And they had that back then, and they would show a high CEA with the different stages of colon cancer. And of course, once you remove the colon cancer, you should have a 0 CEA. So if the CEA bumped up again, you knew you had to have colon cancer somewhere in your body. So we use CEA, not as accurate as some of these methylated ones and all, and certainly not as good as 11 of them together, So, but still, it is something to think about. So those are the tests that we do for screening for colon and rectal cancer. As I mentioned, there's a lot of colon and rectal cancer out there. A lot. It's amazing the number of people who have both colon and rectal cancer. I think on 1 year's time, something like 35,000 died in the United States of colon cancer. That's not the number that had it, because we treat it. But it is a significant problem. Now, we talked about polyps. Now, what about polyps? I mentioned first that there are some inherited, in other words, genetic polyp diseases. People's families who develop loads of different polyps. And some of them could turn cancerous. So it's important when you have a polyp to know, number one, what kind of a polyp is it? And number two, is it cancerous or not? Number three, genetic testing of that polyp. Can you pass it on maybe to your offspring? All those are important things to know. But what about these polyps now? There are several different types of polyps. There are adenomatous polyps, an adenomatous polyp, and two types, villous and tubular. Now the villous look like little fronds, very soft, like a blanket, for God. You feel it? It's like a blanket. Whereas the tubular is more solid. So, but they're both adenomatous polyps. The villous polyp is more prone to develop into a cancer. How long does it take when you're growing a polyp? How long does it take to turn into a cancer? Well, anywhere between 5 to 10 years. This is why it's recommended that you have your colonoscopy every 10 years, because it takes that long for a polyp to develop into a colon cancer. It takes a while, okay? So that's why we have that. The second type of polyp, besides adenomatous, is an inflammatory polyp. This happens mostly with inflammatory bowel disease. You shed a lot of the lining of the colon, and you leave a shred, looks like a polyp and all. Inflammatory polyp disease. And then there's hyperplastic polyps as well. A lot of irritation and all, and they develop these hyperplastic polyps. They're not cancerous at all. It's the adenomatous polyps that we worry about. Now, not all polyps look like a mushroom. In fact, only 15% look like a mushroom. Most of them are flat, called sessile polyps. So it takes time to identify those polyps. It takes time. A lot of the colonoscopists now, the GI people, actually rely now on artificial intelligence. They see a sessile thing in the colon. They ask their robot, basically, hey, do I have to biopsy this or not? And the robot's supposed to be accurate and tell them. That's one of the good and bad things about AI in medicine. I'm not going to, that's a whole show in itself. But at any rate, this goes on. So a lot of them, like I said, the majority are sessile polyps. How big does a polyp have to be before it turns into a cancer? The answer is about 10 millimeters, 1 centimeter. 10 millimeter polyp. Now you know how big a centimeter is. 2.5 centimeters is 1 inch. So 1 centimeter polyps and above, bigger than that, are at risk for cancer. So smaller polyps are not. But they still should be removed as soon as you see them, because if it's an adenomatous polyp, it's going to continue, and after 10 years or so, increase risk of cancer. Okay, so that's it for the polyps, at any rate. That's for the polyps. We didn't talk about the cost of a lot of these things. The CDC recommends, number one, colonoscopy every 10 years. Or the Cologuard every 5 years. So that's their recommendation. If you get your FIT test, you need to get it every year, because that's a simple test, FIT test. If you're still using the stool-based test, the improved stool-based test, that's every year as well. What's the cost of these things? Cologuard, if you went out, paid it on your own, cost you roughly about $700 to get your Cologuard. In other words, doctor's got to order it first. He's got to order it. You have to get him, force him to order that damn Cologuard, because it's almost as good as the colonoscopy for picking things up. Yes, if it's positive, you may wind up with a colonoscopy, but you may not. So that's the cost of that. The cost of the FIT test, usually that's a heck of a lot cheaper. Certainly much cheaper than the colonoscopy, which is anywhere between $2,500 and $3,500. You definitely want to get coverage for that. Now, there are some insurance companies, they're looking for any reason not to cover something. And so it is possible that you always check with your insurance company before you have it done. And then get your primary care doctor to order the damn thing. The Cologuard gets mailed to your house, very simple to use. Mail it back in the pre-labeled package, and you get your results usually in 3 to 4 days. Very easy to do. Same with the fit test. Same with the fit test. So, okay, so that is the cost and some of the little pitfalls. Now, the last issue I'm going to deal with is who should get a colonoscopy. I had mentioned that back when I was first practicing, you got your colonoscopies every 10 years, starting at age 50. Now, because of a lot of the impetus from a lot of these younger people that are developing it, it's down to age 45. So you start age 45. If you have no polyps seen, no lesions seen, you get it done in 10 years. A lesion seen, polyp seen, negative, 5 years. Okay. So now it's recommended between 45 and 75. Wonderful. Some of the gastroenterologists won't even do the damn thing unless you're younger than 75. My wife suddenly went last year to get a colonoscopy. She's 80. No, God, we don't do them on you. Bullshit. That's what I told them. And so it's ridiculous because older people also develop colon and rectal cancer. So she got it done. She got it done. Make sure you check to see what kind of procedure they did. They said they did a colonoscopy, and what they wound up doing was a sigmoidoscopy. Why did they bill for a colonoscopy? Well, what's the difference? They billed $3,000 for a colonoscopy, and they did a sigmoidoscopy, which is usually billed at about $400 to $500. That's the reason. Money, money, money. Okay, I'm sick of this whole damn thing. So I hope you learned a little bit about colon and rectal cancer, and I hopefully will keep you abreast of all of the different screening things that you can have done. This is Dr. C. Have a great day.